Welcome to Learning Thursdays. My name is Crystal Hewitt-Gill with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Traumatic Loss for Caregivers, the Impact of Suicide and Opioids. And our presenter today is Dr. Vanessa McGann, a clinical psychologist specializing in grief and loss issues. Dr. McGann currently chairs the Loss Division and is co-chair of the Clinician Survivor Task Force of the American Association of Suicidology. Dr. McGann is renowned as an expert on the topics of grief and loss and presents nationally on topics related to suicide assessment, treatment, and aftercare in agencies and schools around the country. She will be joining us in just a moment, but first a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce, as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professions. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays presentation. And now it's time to start the presentation. Welcome to our presenter, Dr. Vanessa McGann.
Thank you. Thank you so much for having me. So yes, I'll be talking about traumatic loss for caregivers, the impact of suicide and opioids. It's a very important and sort of neglected topic. The CDC in 2017 said that there were over 70,000 drug overdose deaths and almost 50,000 deaths by suicide. On an online survey in 2018 from OASAS and OMH, over 70% of professionals said that they've experienced loss of a patient due to overdose, suicide, or other traumatic means. And over 50% want more postvention support. So this talk today will really be about what that grief process is when you lose a client to a traumatic loss, as well as what can be done in terms of postvention to support those who lose somebody to a traumatic death. And what they're usually called is deaths of despair, and I just want to give the sort of definition for this. Deaths of despair are premature deaths due to medical issues secondary to alcohol use, overdose, and suicide. What's happened recently is that there are so many of these premature deaths due to the opioid crisis and the rise in suicides that it's actually shortened that overall average life expectancy rates in the United States. So I think there's a tremendous amount of focus on what to do about these deaths of despair and how to prevent them. I just want to talk a little bit about deaths in general and the grief process surrounding them. If you look at the oval to your right, and you think about deaths on a spectrum, there's a death that you could sort of expect. You know, it might be, I lost my grandmother, she was very old, she'd lived a good life, we sort of expected her death. That's more of the usual type of death. Then there's a subset which is sort of more traumatic, which might be a sudden death that comes out of nowhere. It might be an aneurysm, it might be a heart attack from somebody who doesn't have symptoms that you're not expecting, but it's from some sort of physical condition that you can pretty much wrap your head around. Then there are some violent deaths that are more traumatic than that. They might be the car accident, that might be the accident at work or at home, which is scary and sudden and has a traumatic impact, but you understand pretty much what happened to cause that violent death. And then I would say that there are those deaths of despair, which are not only sudden and violent, but confusing or painful to the extent that there's questions about what actually happened, what was the person's role in it, what was going on for that person in more of a behavioral health sense, which adds to a lot of questions. So the issue, I think, for traumatic loss, when we have a traumatic loss, is it's often sort of a stigmatized loss. The person who died, if they're addicted to drugs, if they're suffering with a mental health condition, we tend to sort of move away from looking at that kind of person and outpouring our care for them. There's what was their role in the death. So I think in that vein, if you're mourning that kind of loss, you tend to get a lot less social support. It's not like people bringing lasagnas and roses and comfort. They don't know what to do, so they may stay away from you. When you're suffering that kind of traumatic loss, it's a more intense loss because, again, those questions, those sort of existential questions about what happened and the images that might be in your head are different from mourning and expected death, where you really understand sort of the causes. And I also think it's less understood, it's less talked about, so it's harder to get your mind around what happened. So I just want to talk a little bit about the differences between deaths of despair, comparing sort of opioid deaths and suicides. I'll start with talking about opioid deaths and overdose deaths. The people who die with opioid deaths are substance abusers, with all the sort of ideas our society has about drug addicts, about their lives, their struggles, both good and bad. And I think one particular thing in terms of these deaths of despair is the increase recently, the sort of rapid increase in how many of the deaths that there are. So especially mental health workers who are working with substance abusers are really having the onslaught of finding out, hearing about deaths, having many more deaths in their caseload than they ever did before. And I think that has an impact on how they're grieving. I think there's a question of preventability with drug overdoses. Again, the circumstances can vary so much. You can lose somebody who's had many overdoses and then finally dies by an overdose. You can have somebody who's just experimenting and then they get a bad batch of something, and what would it have needed in order to prevent that? You could have somebody who's been clean for quite a long time and then relapses and dies. So I think the question of preventability changes depending on the circumstance of the death. I think there are questions with this in terms of our society blaming the person who's died. That's a little bit similar to the suicide, but just in terms of the addictions and the relationship with drug use. By definition, if it's an overdose and not a suicide, it's an accident. So there's that reaction to that of, why did this have to happen? What could have prevented it, in the way of not having much control over the outcome. And then I think there's a lot of focus on the opioid deaths these days. So there's a lot of issues in terms of liability and who's going to be looking at what was done and was everything done well. So in terms of the risk for the professional caretaker, the anxiety goes up a lot because of the liability issues. And finally, I think because the field is so new to all of these deaths, I think there's a lot fewer options out there for postvention supports, and I think the field is generally learning now. I think this talk is part of the learning to figure out what sort of supports can be in place for caretakers who lose somebody to a drug overdose death. In comparison with suicide, I think instead of the sort of ideas about drug addicts, you have the mentally ill, you have the crazies and things like that, and the sort of stigma around mental health issues. I do think there's a little bit more literature and support on these issues, and the question of preventability is different because it was a self-inflicted death rather than potentially an accident. There are still liability issues if you're worried about getting sued when your charts are being examined. The anxiety, the difficulty with dealing with the death gets more intense. But I do think that there's relatively more supports out there and postvention protocols from the suicide part of these deaths. In terms of these deaths of despair, I just want to talk a little bit about the ambiguous death, because some of them, and many of them, honestly, are not very clear whether it was an overdose death to an accident, a bad batch, somebody didn't know the potency, the toxicity of something, or whether it was a suicide. And I think that leads to a lot of sort of angst by the professional caregiver. It's harder to mourn the sort of death where you're not sure what it was, whether it was an accident or a suicide, whether it was self-inflicted or unintentional. So now I want to just talk about aspects of traumatic grief, and this would really be true if it was a family member, if it was a professional caregiver, a counselor. When you hear about a death, you have an initial shock and numbness. Oftentimes there can be sort of a hopelessness about the whole situation in general, about deaths of despair. There can be things like depression, weeping. There's a lot of guilt. I call it sort of the unholy trinity of guilt, shame, and anger when you hear about these things. It's a very intense processing of the loss. Oftentimes when there's a traumatic death, people really have existential questions of what's the meaning of the work I do? What's the meaning of trying to make any kind of forward motion in this field? Is anything I do going to help anything? And what's the purpose in general? Why are there drugs? Why is there pain? You know, why does suicide exist? Why is addiction so prevalent? All those sort of questions that can really start plaguing you, more than just the actual loss, but just what's the point of it all. I think another thing that can happen is sort of PTSD symptoms. Sometimes somebody will get a call about a death, and then whenever the phone rings, they'll get a jolt and they'll have that kind of reaction. I mean, it can be very unsettling to feel like there's this part of your body, part of your senses that's sort of not in control, but can be brought into some sort of panic at any time. And I do want to say that there's also the potential, ultimately, of some kind of growth from the traumatic loss. Because oftentimes, after those existential questions, the way people really try and grapple with it and work through it can help improve their sense of competence, their sense of safety, their sense of compassion towards others. So that's something that shouldn't be forgotten with sort of the aftermath of a traumatic loss. But let's talk about it in terms of mental health professionals, caregivers in general. I think some of the factors that can affect how deeply you grieve, how difficult the grief process is how long you've been in treatment with the person, how well you've known them. The quality of the relationship, it might not necessarily be how close you are to them. Sometimes you can be really bored by them. You can feel like you're zoning out or feeling a little bit hopeless. And then if you lose somebody, it's all the more difficult because you feel guilty about not feeling that tuned in and connected to them. I've already mentioned the circumstances around the death can really change the impact of the death. If it's sudden, if it just came out of nowhere compared to if you had an idea that they were really struggling, and they might decide to relapse or take their life. Another thing that I think we seldom think about is our own background and what goes into the impact of the loss for us. Sometimes we've had our own losses and traumas, and if we haven't really worked through those, another loss on top of that can really push us back and make us grapple with managing. How long we've been in the field, unfortunately, a lot of trainees lose people to deaths of despair much more often than people who are further along in the field, mostly because they're working with people who have dual diagnoses, who are sort of the hardest to treat. And it's not because of a lack of skill, but it's because they're dealing with the hardest cases. And if you're in the field longer, you tend to have more administrative responsibilities and things like that. But for that trainee, it's such a gut-wrenching, scary experience to think, did I not have the skill? Am I not cut out for this field? It can be very difficult when you're just starting out. And then finally, I want to say that sort of our orientation for the work, I think, affects us. A lot of psychiatrists who are built with a medical model who feel like if you're working with cancer patients, you're going to lose certain people to cancer. That sort of attitude towards our work, I think, has a little bit of a protective factor compared to if you really feel like you can save people and it's your job to fix everything, and you sort of take the work personally in terms of your sense of responsibility. Then I think also there's things that are particular to being a caretaker that are very hard in terms of the grief process. If I lose a friend to a death of despair, what do I get to do? I get to talk to all my other friends about it. I get to go to the funeral. I get to participate in rituals. I can hold their things that keep me close to them as part of the healthy grieving process. But in terms of being a clinician, the extent to which we can really talk about it and acknowledge that relationship is very circumscribed. We often don't get to go to the funeral. We don't get to hear stories from anybody else about the person we were working with. We don't get to sort of have that communal process of grieving. And we don't get to see how other people are doing and sort of revisit it in the way it's all very much sort of sequestered into our own personal space to try and figure out and hold and work through that grief ourselves. So I think all of those things can be particularly difficult for dealing with a death of despair if you're a clinician. What can help? Definitely agency support, other colleagues supporting you. I'll get into this, but oftentimes that's lacking and that can really get in the way. But agency support for the loss, knowing that these losses are going to happen, knowing sort of how to support somebody can be a huge blessing. If there's a lack of professional stigma around it, if other people where you're working have lost people, so they accept it, they accept you, they're not casting any kind of blame or suspicion or questioning your judgment in terms of your clinical work, that can really help. If there is anger from the family, any kind of blame, that can really hinder the process of grieving the loss. And definitely if there is any kind of lawsuit, that gets in the way of the grieving. And just a note on that, there's a couple of ways it gets in the grieving. I was talking about before about how you get to go to funerals and go to rituals if you are a friend. If there's a lawsuit, you don't have any control over how long the process is going to take, over when you're going to be called in to have a chart review, to do a deposition, and you're not going to know how long it's going to take to resolve itself. It's an external thing that's bringing this on to you, so that really gets in the way of healthy grieving and processing of the loss. I just think it's also important to talk about professional stigma because I think it's so strong, and I think this is really for people who are going through this kind of death of despair, grief. This is the thing that gets in the way often the most. In the same way that there's stigma around drug users or people who have mental health conditions, there can be stigma against a clinician who loses somebody with one of those issues. There's sort of an us-them mentality where maybe before you've had that loss, everybody's a great clinician, everybody's supporting each other. But as soon as the clinician starts to be grieving, there's a little bit of a questioning. Oh, why did that happen to them? That wouldn't happen to me, would it? Why are they grieving that way? I think they're grieving too much. I don't think they're grieving enough. There's sort of a insidious blame or judgment or questioning that for the person who's grieving can feel really terrible because they can sense when they walk into a room that people are kind of responding to them a little bit differently than that they used to be responding to them before the death. And I think also, even if it's not sort of a question about their judgment or a question about their competence or a question about how they're grieving, I think oftentimes there's just a question to know what to do. Should I bring up the death? Should I not bring it up? So people tend to stay away from the person who's sort of in the midst of that intense grief. And instead of that helping the person, giving that more space, it sort of ups the ante and makes their grief process more full of anguish and despair. So what can this do? What's the impact of having a loss like this? Well, it can definitely lead you to question your own clinical competence, how good you are as a therapist. You can question whether you were somehow responsible, whether it was your fault that this occurred, if you hadn't done this clinical intervention, if only you had called the person to check up on them. It can really bring up all those questions of why. And it can lead to a lot of distress and burnout, and it can affect your clinical care of other people that you're working with. Herb Hendon has done a lot of research on this, and most people say it's if they lose somebody to a death of despair, it's the worst thing that's happened to them professionally. We don't have a lot of good statistics on how many people leave the field, but just anecdotally, because this is my specialty and I talk to administrators of large hospitals, a lot of people who have a death like this say, I quit, I'm out, I can't do it anymore. So I think it's really important that we figure out how to support people better after this kind of loss. I just want to talk a little bit more about the clinical work that happens, especially right after you have a loss. And I usually say it can be on a spectrum from sort of numbing yourself completely and being sort of scared of contacting any of the patient's struggles or pains, to being incredibly anxious and hypervigilant and looking at everything as some kind of a sign of some kind of danger and just not trusting anything that you see. Some people tend to sort of become very intellectualized therapists and just talk about things and really shy away from any affect that's going on in the room. And some people just get totally emotionally flooded when they're with a client who's struggling a lot with their feelings. I say sometimes people end up being very CBT, sort of like, are you doing yoga? Are you exercising? Are you doing this? And sort of trying to put Band-Aids on the struggles that the person's going into. Or they can get sort of into this existential question about whether or not there can be hope in this world, and stay there and not really hold some hope and contain the pain for the client, but just sort of join them in it. It can be really scary. I don't know if you guys are picking this up from what I'm saying, but to lose your clinical footing and to not feel that balance and that strength and that confidence in yourself can be very unnerving. Another thing that I think happens often to us in our field is we say, bring it on, you know, let me work more so I can show you guys how I can stay afoot and manage. And oftentimes, ironically, terribly, people who have a loss like this end up getting more of the most difficult clients, and that can lead to a lot of feelings of being overwhelmed and I don't know if I can handle this anymore, because they just want to sort of take on in order to keep going. You can also be absent. You can have difficulty following up with paperwork, phone calls, all the ancillary things that have to do with clinical work. And you can basically have trouble trusting in what you're seeing in front of you. You know, I think one of the times that this is particularly true is if you are working with someone where their death was not really on the radar. If there's lots of warning signs, if there's lots of clinical implications, you say, okay, we're making a safety plan, we're figuring this out, we're using all the interventions that we know to keep this person afloat. But if they were just coming in and saying, you know, I've been clean for 7 months, I'm feeling great, or if they're not talking about suicide, nothing is there to make you worried, and then all of a sudden you get a call that the person's dead, it can really affect your ability to trust whatever's in front of you after that when you're working with somebody. So, what do we do? I want to talk about postvention, and particularly postvention for clinicians, but also postvention in general for agencies and for other clients that might be affected by a death, because you might be working in a milieu setting in a hospital. So not only the clinician, but the team and the rest of the clients or patients need to be looked after. Postvention is an organized response in the aftermath of a traumatic loss to accomplish any of one of the following. It's to facilitate healing from grief, distress, and loss, to mitigate other negative effects of exposures to loss, and to prevent further loss among people who are at risk after an exposure to a death. And I just want to quote Edmund Schneidman, who says, Postvention is prevention for the next generation. And I think that as these rates of suicide and overdose deaths have climbed, it's really important that we think about that. We need to be paying attention to good postvention in order to prevent more deaths. He also says that a benign society ought routinely provide postvention, and I want you all to think in this presentation how much postvention there has been when your agency or you have had a death of despair. So let's talk about the optimal postvention support for caregivers. First and foremost, I think there must be training around deaths of despair and the potential aftermath. The best thing and the thing that happens, I think, after a clinician goes through this is they educate themselves. They educate themselves in terms of prevention. They educate themselves on how to do the best assessment. They educate themselves on how to note what they're doing in the most efficacious manner. And I think if you do that and you know that your clinical thinking is on target and you've noted what you've done, which makes sense well, then you'll have less doubts if and when a patient does die that you missed something, that you didn't note it right, that you're exposed for liability or you're exposed to just questioning your own clinical competence. So that's really important, is before the event ever happens, to sort of know what you're working with and know how to note it. Another thing that I think happens is a death happens and everybody's just confused as to what to do. There's not a thorough enough protocol or protocols into how to manage the sort of situation. Everybody gets frightened. Who do we tell? What do we have to look at? How do we change things? What kind of liability can happen? If something's written out ahead of time, can keep everybody calm, can keep everybody relatively collected, and you can feel somewhat of a sense of control. Another thing that has to happen and should happen is a case review, and I think that that should often be separated into a case review for the agency and then a case review for the clinician, so they can really look at their own clinical work and digest it with a supportive supervisor in a separate session from all of the administrators or legal risk management people who might be involved. Supportive supervision and consultation should be there. And also, at times, but you really need to check with your agency, some kind of family contact protocols should be in place, because there's often a question about whether to reach out, whether not to reach out, what the issues of confidentiality are, and you need to be very careful about that. So it's good to have those sort of ideas and protocols in place. But if all these things are there, and if you've rehearsed them a little bit, you should have a better time in the immediate aftermath of a death, feeling like there's a way to go, we're in control, we can manage this, and we can learn from it. I just want to go into a little bit more details about the postvention elements. The training beforehand, we should be trained on assessment and chart notation to minimize litigation. We should know about common grief reactions, so when we see it in our colleague, we don't think, oh my goodness, they're crying too much, or oh my goodness, they're not crying at all. Everybody grieves differently. Some people need space, some people need hugs, and I think if everybody's aware of the different things that people need, they might be more likely to give it to them. And also there should be a plan of action in terms of point people to go to manage the traumatic loss, because excuse me, oftentimes with these, there's rumors, there's gossip, there's details, and the most helpful thing is to say, you know, I don't know all the things, but if you have questions, why don't you go to this person? That can be incredibly helpful in the immediate aftermath of a death. I just want to talk about the initial debriefing, which I think is really important. Gather your staff together, gather these staff together. It's just a time where you're going to say, this happened, this is what we know, how's everybody feeling, we're a team, we can get through this. Try not to blame each other, try not to have rumors about this. Everybody's scared, everybody's a little wonky, but let's have some extra compassion for each other and take care of each other. And it's just a little time to breathe, to make sure that people aren't getting too hysterical, to make sure that there aren't particular issues based on the circumstances that really need to get taken care of. Let's say there was another client in your agency who heard about it beforehand, so you might want to check in on them. It's just sort of a time to gather together, get the facts, and have compassion for each other before you go forth and do anything else. And I just want to sort of say this is different than a critical incident stress debriefing, which is really if you have an overwhelming, impactful thing where most of your staff are going to be feeling symptoms of intense trauma. There's sort of another protocol to go through that I'm not going to get into detail about today. Also, in terms of the postvention elements, you should have a plan on how to contact other clients about the death. You have to contact the legal department, the malpractice insurance, and schedule some sort of chart review. Depending on where you are, what kind of a milieu treatment it is, you might want to think about a way to have people come together to say goodbye and have some sort of little memorial, just as that sort of piece of it that can add to the closure and the ritual that can be healing for a lot of people so they can sort of pay their respects. And you want to figure out how you can offer extra time and space for grief reactions. You might want to have drop-in sessions available. You might want to tell your staff that, no matter what, they should check in with their patient or client to see if they've heard of the death, to see how they're doing about it, and to do some kind of a sort of, suicide or risk assessment to make sure that everybody's safe. I want to talk a little bit about the case review or the root cause analysis. Oftentimes, because I talk to so many clinicians who have had a traumatic loss, they say it's like a military tribunal. They feel very blamed, they feel very attacked. And I think particularly administrators, when you're thinking about how to work with these deaths, you need to look at it as a holistic approach to your entire agency and to see if there's any lessons learned, not about that particular clinician that was working with that client, but in terms of the system and what could be better. Is there a waiting time? How much supervision is available? Are the charts looked at? How is risk assessed? Do we need to have another sort of training on risk assessment? All of those sorts of things, rather than just looking at what the particular caregiver did or didn't do. And then I think separate from that, absolutely separate for as long as it needs to be, the clinician needs to have a space to really go over their work and talk to a supportive supervisor. It shouldn't be rushed. In order to get through this sort of loss, you need to really have the space to question yourself, to look at everything again and again and again until you don't need to do it anymore. I think when these things are sort of very superficial and rushed, it can get caught in the clinician and they'll have more trouble later sort of working it through and regaining their clinical competence. In terms of support, which I think is so key for this, there's lots of different ways that you can lend support. Some clinicians might not want such a high-risk caseload, and if you can figure out a way of doing that for them, that's great. Some clinicians might want an extra amount of supervision. If you can do that, that's great. If they don't want as much crisis work, walk-in stuff, and you can accommodate that, any kind of support that you can do that I acknowledge that you might be having a hard time, the more I can support the fact that that's true, the faster you'll be able to sort of get back on your feet and go back to your normal caseload and your normal ability to feel solid with your clinical work. There's also therapy that you can suggest or offer in terms of maybe there's an EAP that could offer some sort of support or personal individual therapy. Especially, I want to add, sometimes clinicians get worried about talking about the details. That's a confidential space for them where they can really be free to talk about any emotion, any feeling of guilt, any anger, any questioning. It's just their space for them. So that can be incredibly helpful as an intervention. But I would be remiss after all of these worries and all of these desperate needs for support to not talk about what can ultimately come out of this, which I believe to be post-traumatic growth. And I'll talk a little bit at the end about a task force I have, but I've seen a lot of clinicians come in feeling very broken and scared and confused, and over time feel incredibly, what would the word be? Incredibly sort of strengthened. And whereas at first they have doubts about their clinical competence, they actually feel more clinically competent after a loss like that. So I want to talk a little bit about how that might happen. I think that most clinicians who go through this kind of loss, they want to learn everything about addiction. They want to learn everything about assessment. They want to learn everything about suicide. And in doing that, they get a lot of information on how to assess, how to manage, how to think about the person that's right in front of them. I also think that they gain a little bit of a different sense of their work through those existential questions, and they gain a little bit of comfort with just looking at pain and looking at struggle and looking at people really finding a hard time managing. And in a way, because their heart sort of becomes more open, they're more able to contact and effectively work with people if they have, worked through the grief and gotten to a different place from it. I think there is a lack of grandiosity once you go through this, to say the least. I think people become very humble, but I think in that sort of humble sense of themselves, there can also be a real power. And I think that also there's sort of a sense of who they are as not just a clinician or just somebody grieving, but a clinician who's gone through a really difficult experience, and they can kind of own those two sides of themselves, and that also can really bring them sort of power and wisdom in what they do. And last, I would say that working with a lot of clinicians like this, like myself, I can talk about that later when we're talking about why I got to this topic and why it's so important to me. I lost my sister to suicide. I think there's a lot of desire to give back to the community and to say, you know what, I went through a terrible time after my client died. I don't want that to happen to somebody else. So I'm going to see how I can do with my supervision, with just informally sort of talking to people about this and training them and helping them to get through a traumatic loss. So let me just talk a little bit about how I came to this. I work with the American Association of Suicidology. I'm a board member, and we have a task force for clinicians who have lost someone to suicide. AAS has a great network of crisis workers and researchers and preventionists and people who are looking at helping survivors of suicide loss, family members. But for a long time, there wasn't something particularly for clinicians. And it was really sort of almost, I don't want to say the last or the most stigmatized group, because I think some people who have attempted suicide, who have lived experience, feel that way. But there wasn't really anywhere to go for people to talk about that. So my colleague Nina Guten and I have sort of created a space. Mostly what it is a website that has a bibliography on everything that's been written about clinicians who particularly lose a client or a family member to suicide, not overdose. It has testimonials about what it's been like for people who have lost a client. It has a bunch of postvention protocols that can be helpful if you're in private practice or if you're in an agency. Again, check with your agency. Don't just use what's on our website, because you want to make sure with your legal team and malpractice carrier that you're doing the right things. And then the other thing it has is a listserv, so people can join the listserv, sort of talk about what they're going through, ask any questions, get a whole bunch of support, and also learn how to educate people in their community and how to support people in their community who are going through this kind of loss.
I'd just like to take a moment to direct people's attention to two clinical documents that OASAS has released in the past year. The first is Clinical Response Following Opioid Overdose, a guide for managers, which provides some practical strategies for postvention protocols in different agencies. And the second is Overdose Prevention and Response in Behavioral Health Settings, which again is intended for all behavioral health workers who may be dealing with the issue of overdose in their respective agency. Links to these documents can be accessed on the OASAS website at the following links. I'd like to thank Dr. Vanessa McGann, our presenter for today's program. I'd also like to extend a thank you to Gary Lloyd-Lester for joining us today. I hope you'll all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your expectations and educational goals. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.